So it's a mouthful what you were describing of the patient population for this study. So I'm going to take us back to that cancer car analogy. This is a subset of patients who have had different changes in their DNA that are driving their cancer from the HER2 positive metastatic breast cancer patients we were talking about before. So this subset of patients have estrogen receptor positive disease, meaning they have estrogen receptors on the outside of their cancer cells. And typically, presence of estrogen drives more cancer growth. So traditional treatments for estrogen receptor positive cancer, one layer of that has focused on decreasing estrogen in the body or blocking that receptor. So when we say ESR1 mutated breast cancer, ESR1 is the gene that encodes the estrogen receptor. So patients who have ESR1 mutated estrogen receptor positive breast cancer tend to have resistance to standard endocrine therapies. What that means is that those gene changes as the DNA, the car is driving 90 miles an hour, the DNA base pairs that encode that ESR1 gene, they change enough that the gene is the protein that gets made from that gene, the estrogen receptor, is what we call constitutively active. It's always on. It doesn't need estrogen to be present to make it drive cancer cell growth. That makes estrogen, the traditional ways of decreasing estrogen or blocking estrogen less effective in treating that type of cancer. So that has led to, again, that's the basic science, and then the hope is that we come up with medications that can counterbalance that. There is a newer class of medications called selective estrogen receptor degraders. So instead of trying to block the estrogen receptor, they try and destroy that estrogen receptor so that it can no longer be driving cancer cell growth. So that's the particular biologic challenge for people who have this particular type of breast cancer. Sure. So again, the mouthful that you said at the beginning is that this is for patients with this subset of breast cancer type, so estrogen receptor positive, HER2 negative breast cancer, who have already had other treatments and progressed through those treatments. So again, those other treatments are the standard ways that we think about treating estrogen receptor positive breast cancer. So what this trial was doing was it was looking at the addition or using this novel type of medicine, the one that's going to degrade the estrogen receptor instead of just block the estrogen receptor. And patients on this trial could have that ESR1 mutation, or they did not have to have the ESR1 mutation. So, and they were looking at both groups, like as a whole, did adding this type of medication make a difference? And they look specifically, did it make a difference for people who have this ESR1 mutation? And really the overall takeaway is for that subset of patients, those who have the ESR1 mutation, that this new type of medication was more effective for those patients. So it seems like a really promising new opportunity to treat the disease that's difficult when you have a particular gene mutation that's making your estrogen receptors behave differently on the cancer cells. So I think it's a blessing and a curse that cancer care is getting more and more and more subgrouped, meaning, it takes 2 minutes to just say out loud the characteristics that put people into one specific group of a cancer type. It's great that we're getting able to get down to that level of detail to understand individual cancer subtypes, but it means that it is also more complicated to know what to do for those groups of patients. I think it's likely that these types of medications are going to have the most benefit in people with these types of mutations driving their cancer cell growth. But it means we need to then now study a smaller subpopulation of patients, just the ESR1 mutated patients with these types of medicines, to really see, again, duration of therapy, sequencing of therapy. Where do we put this in? How do we determine who is most likely to benefit from it? Are there, and how do we know how long to treat? So it's just going to take more time to be able to gather the information that we need from a promising early signal that this is an improvement over other standard therapies to really know how to maximize benefit. There's a big difference in between knowing that this is better than what we have versus knowing what is actually best. And so I think that's the challenge for that's the next challenge and hurdle to cross here, is to figure out how to best use this new class of medications for estrogen receptor positive breast cancer to maximize benefit for patients. My understanding is the study, again, had a broader inclusion criteria than just the population where we're seeing benefit. So that means that in general, the study isn't powered or didn't have enough patients in a particular subset to be able to do multiple layers of more complex analysis. So that's where I was saying, I think one limitation is, again, knowing exactly how to deploy this for individual patients, and how to deploy it at like the population level for patients with this subgroup of breast cancer. It also begs the question of how and when we use testing to understand the changes driving the cancer growth. So going back to that car analogy, as I described, the car is going 90 miles an hour. It's pretty standard there are tests that we can do that can check the DNA at any point in time in the cancer cells and say, these are all the genes that have been mutated and that are likely contributing to cancer. But for the cells that are going 90 miles an hour, that changes over time, right? So this is the whole point, is that it's going 90 down every street. And so each time that cell divides and copies, there's an opportunity for more errors to happen. And so I think as a community, we're still trying to understand how and when to check back and see, has something changed yet? It's obvious to check after someone's cancer has progressed, but that also feels like you're behind the 8 ball, right? Like the cancer is telling you that it has figured out a way to evade the treatments that you're using. So like most likely there are going to be changes in the DNA that are leading to that. But ideally, we'd like to be able to get ahead of that, to be able to see the changes in the DNA before the person has the clinical progression, and see if we can get smarter about doing that so that we can have people feeling better for longer and just being more nimble about the ability to switch medications. So I think that is going to be a continued area of a lot of focus and research, not just in this subpopulation of breast cancer patients, but in breast cancer as a whole.